view of EMR versus ESD. My take on it, based on evidence. So, because we're in Sochi, I think this analogy is suitable. I'm a keen skier. I like skiing. I go down the hill, 2 skis, 2 poles. It's safe. I can go down any hill. It might not be elegant, but it gets me down. But my children, they don't want to do that. They want to snowboard. So no, why do you want to snowboard? It's slower. You're more likely to fall over, and I'll have to wait for you at the bottom of the hill, and I have to buy you another. You have perfectly good skis. Now you want new ski boots, and you want a board. It's expensive, and it's exactly the same argument with EMR and ESD, of course. It gets you down. It does the job, but one is takes longer, more expensive, and is more awkward. What's the point? Why am I doing it? Well, the ESD people say, yeah. The reason we do it is because there's so many fewer local recurrences. That's what we do. That's what we do it. It's not because it's cool. It's because of the local recurrences. And of course, the early studies did suggest that there was a high risk of local recurrence of polyp with EMR. The first study, that 27%. There's been a meta-analysis of all the studies, and the bottom line is that yes, they have a point. The risk of a local recurrence after an EMR is something like 10% in the published studies, but after ESD is something like a bit over 1%. So this seems like they're winning the argument, but I don't buy it. You see, what predicts a local recurrence is not the ESD versus EMR, it's how difficult the polypectomy is. That's what makes it. You know, when I'm removing an 8 centimeter polyp behind a fold in the cecum, and I can barely see things because it's a really difficult position, that's when I get a local recurrence, not with a big, easy 3 centimeter polyp in the rectum. So we recently did this analysis in Leeds. 6.5% local recurrence rate, but virtually all those recurrences happen in big, what we call level 4 polyps. I'm not sure if you're familiar with the SMSA scoring system. Basically, it's size, morphology, site, left or right side of the colon, and the axis. And on that you can kind of develop a scoring system, and level 4 polyps are basically the hardest. So that's where you get the local recurrence. So I think it's an unfair comparison. You see, that 8 centimeter hard to reach polyp in the cecum, no one would do ESD for it anyway. It's too damn difficult. So those patients are probably sent for piecemeal EMR and for surgery. Or they come for a piecemeal resection with me. So I take out all the hard polyps, and then my ESD friends, they take out the easy ones and say, look, we're so good. There's no local recurrence because you're removing polyps that I can remove in 10 minutes. That's why. And you take 2 hours to do it. The other thing is, I don't think local recurrence is a big deal. Look at this. With the white light you can't see it, but spray a bit of blue dye and you can see a few little islands after 6 months of local recurrence. A bit of APC is gone. Big deal. Took me 5 minutes. Okay, big deal. But how about the dangers of ESD? I mean, snowboarding is more dangerous than skiing. ESD is more dangerous than EMR. In Leeds, we compared our data with Keio University in Tokyo a few years ago, and basically the perforation rate in Keio University Hospital was 4.8%, and the delayed perforations, you can get delayed perforations after EMR, was 0.6%, and delayed bleeding 3%. And bleeding rate was the same, more or less, between Keio University and Leeds, but the perforation rate was way worse. We only had 1 perforation. And more recently, there's been a meta-analysis, and basically mirroring the results, the comparison between Leeds and Keio University, the risk of late bleeding is the same. And late bleeding is an issue, actually. I agree with Katarina on that. We should do our best to reduce the risk of it. Clips are good. They're expensive, they're not cost effective, but it's just the right thing to do. You don't want this 80-year-old lady come back to hospital with blood pouring out of her bottom end. That's not nice. She can get a heart attack, stroke, and all sorts of things. We should do what we can to avoid it. Why do I wash hands between my patients? What's the evidence for that then? I wear gloves anyway. It's just the right thing to do. It's the same with clips. It's the right thing to do, even if it costs a few bob. So there's no significant difference in late bleeding, EMR versus ESD. And why would it be? It shouldn't be, really. How about the risk of perforation? Here's a small microperforation. Big deal, you might say. That little hole, 2 clips, it's done, finished, cleared. Of course, in the meta-analysis, the risk of perforation was very similar, a little bit worse than my own figure, 0.9%, so 1% of EMRs complicated about perforation compared to virtually 5% of ESD. So there's no doubt about it, you get more perforations. But does it matter? A small perforation like that, 2 clips, done. Well, it might matter if you're removing a cancer. Would you like to perforate a cancer? The surgeons sitting over there would be appalled. You potentially turn a T1A cancer into T4 cancer. Who knows? I've asked the Japanese this, and they don't like to wash their dirty linen in public. And they say, we have seen it. We have seen it. Yeah, upstaging to T4 disease. So perforating a cancer is a bad idea. We should avoid it. Of course, perforations are often difficult to spot if you don't tune your eye into it. This is a perforation here. I remember the junior that did this procedure with me said, "That's not a perforation. I can't see no gallbladder or anything." Well, the perforation's gone into the kind of omental reflection, of course. So you have kind of pericolic fat here. But it's not that wide open perforation, but it would be if you don't close it. And if in doubt, turn the specimen over and look for that little disc of muscle propria inside the resection specimen, and then the target side, then it's a perforation. If in doubt, the third sign is that the patient starts to get uncomfortable very quickly. Close it, put clips on, but you always do anyway. So, if you speak to a surgeon, they say, look, you guys, we can remove things single fragment. We can do TEMS, transanal resection. We're really good at it. And it's much better than your cack-handed, piecemeal resections. But it isn't really, it's worse. Surgeons do a heck of a lot worse job. Look at this comparison from Holland. Lesions were very similar. Perforation rate was 12% with TEMS. They perforate twice as many, 3 times as many cases as we do. The complications needing surgery in 1 in 20 cases, and late recurrence rate was no better. So the surgeons are worse than us. So my first job, I say to my surgical friends, my job is to keep you away from my patients, because you're way more expensive, way more dangerous, and you shouldn't be anywhere near lesions which I can remove myself. But of course I do take that point. They like single fragment. At this point, let's weigh up the pros and cons. EMR is safer and it's cheaper. But the ESD people haven't given up yet. They said, look. We're still better because we can save people an operation if they've got a malignant polyp. How does that work then? How? Well, they say, we cut much deeper. We cut much deeper, Dr. Rembacken. You see, you cut here. And we cut much deeper. I don't know. There's no evidence for that at all. It's all in their heads. There's not been a single study, as far as I know, comparing the kind of depth of cutting. And I cut deep sometimes. Have a look at this thing. Sessile polyp. Of course, sessile polyp, the surface glands, surface crypt pattern, doesn't tell you what's happening deep inside it. This is actually a small malignant polyp, deep focus inside it. But it seems to be lifting. I put a snare around it, and I take the tip of the muscle propria layer off with it, like that. I cut deep. I cut into, I remove part of the muscle program. Don't tell me that you don't go deeper than I do. If necessary, hell, I cut straight through. My worst case was a polypectomy, and the histology came back as T3 disease with serosal margin free of tumor. But T3 cancer, that's polypectomy. You wouldn't get that from an ESD. Bit of a mistake, of course. So I don't buy it. ESD does not cut deeper. And when you're beginning with ESD, then you're cutting very, very shallowly, because you're trying to keep way away from the muscle layer, because you're scared of kind of cutting into it. It's very thin. But could it make it easier for the pathologists? You know, we all know pathologists. They're very unhappy people. You give them biopsy, they can't really make the diagnosis. They want the polyp. Please give me the polyp. You give them the polyp in pieces, and no. We want it as a single piece. You give them the polyp as a single piece and say, no. We want the colectomy. Could you give us the colectomy specimen? Oh, you give them the colectomy, they say, well, could we have the post-mortem specimen? They are unhappy people. You will never please them. Okay, just accept it. But they do moan when we give them a piecemeal resection, and the reason is this. So this is a single fragment resection, and if you magnify it, you'll see that down at the bottom there where there's a ring, there's a small spot of cancer. And if you remove it as a single fragment, the pathologist can say, okay, I can make a diagnosis of cancer, and I could do that whether it's piecemeal or not, but here I can say you got it all out, doc. It's all gone. And if I'd given it in pieces and I cut one cut here, then they would have had to say, well, the deep margin we think is clear, but the lateral margin is probably involved, and we see cancer in several pieces. We can't tell it's all out or not. And then, it's a bit anxious. Should you say, Mrs. Smith, you'll probably be okay. We don't know, you have cancer. We think we removed it, but we're not sure. Do you feel lucky? A little bit uncomfortable. More often than not, we say, we'll send you for surgery. So perhaps I'll buy that argument. There's a few conclusions about ESD and cancer. I don't think there's any evidence that ESD cuts deep or anything like that, as I said, and it's more curative in any way. But I do accept that perhaps the pathologists do find it easier to declare that all of that little spot of microinvasion is completely gone. And of course, we know that if the cancer doesn't extend any deeper than up to a millimeter or so, you probably cure the patient with endoscopic means, provided that it's not a poor differentiation, provided there's not lymphovascular invasion, and the margins are clear. And there is one other thing, and that is here's a malignant polyp, and I removed it piecemeal until I was surprised to see this kind of area in the center. And what you see here, underneath the cancer, you get fibrous tissue, desmoplastic reaction. And of course, if I was kind of ESDing here, I would get to this point and I realize, this is cancer, and that I would just back off. But if I just put the snare around it and cut straight through here, I will only realize it's cancer once the thing has come off, so to speak. Because I wouldn't realize that deep inside the lesion there is no lifting. With that sessile polyp, sometimes you just can't tell. You put a snare around it and hope for the best. So ESD maybe has an edge there. So to conclude, when does ESD have a role then? When should you use it? Well, these are my kind of indications. They're unacceptable, but I think they're sensible. Large sessile lesions like this, you can't tell what's going on underneath it. It might be cancer. The surface strip pattern can't tell you. So you can ESD it and see. If you hit this desmoplasia, you back off. It was cancer underneath it. Lesions like this is an LSTD type, a kind of a depressed lesion. You simply can't remove it by EMR because the darn things won't lift. So the only way to remove it is by ESD. Same with LST-NG lesions like that. You can't remove it by injecting it into it because they don't lift. There's a question mark around the LST-M mixed type lesions where there's a flat component and then there's a dominant nodule, whether they should be removed a single fragment too. to be honest, I think if I just remove that bit, single fragment, if there is a cancer underneath this lesion, it's underneath this spot. There's no cancer here or here, would never be. If there's cancer, it would be here. So maybe just removing that piece, you know, as a single particular block, probably is good enough, I think. So the problem is that if you've got an ESDist in your department, they're like a guy with a hammer, and everything is a nail, and they just attack. You can't stop them. And there are lesions like this which are not lifting. These are examples of the non-lifting side. That thing here is not lifting. Back off, back off, back off. It's not an indication for ESD or EMR. This lesion here is not lifting. Back off. This cancer here is not lifting. Back off. This cancer here is not lifting. Back off. And if you've got a guy with an ESD, they're often, you can't stop them. They don't want to practice, don't they? They want to do a lot of it. They want to get better because they're rubbish. And because we're all rubbish when we start doing something. You know, this might look like a suitable candidate. It isn't. It's a cancer. Don't go anywhere near it. This is the danger. And there are some unintended consequences of ESD. If we're going to go with it, things are going to change in endoscopy. If a single fragment is the way we should do it, then there should always be single fragment in the rectum and in the cecum. Probably everywhere. Maybe in the esophagus and the stomach too. Always okay. If this is what the guys want of me, then I can provide it. It'll be expensive, it'll take more time. Because all lesions, all GI lesions, not just the colon, but all GI lesions should probably remove as a single fragment. And of course, not everyone can be taught it. If this is what they want, then you couldn't get, you know, all the endoscopists couldn't learn it because you'll be doing, I don't know, 10, 15 ESDs a year. It's not good enough. You need to do it, probably, in Japan they say at least twice a week, but that's if you're fully trained. And it probably takes a couple of hundred to get fully trained. So you probably need to, you know, you need to concentrate the polyps in a few hands. So not everyone could do it. Only one guy. So in Katarina's department, only Katarina could do it. No one else can go anywhere near polyps if they're bigger than, say, 2 centimeters or so. You know, it will have big repercussions. There'll be a lot of people who are upset. Said, I've been doing polyps for 20 years. Why can't I continue to do it? It's unfair. It's not right. I'm perfectly safe. And of course, it will cost money because to ESD something takes 2 or 3 hours. Certainly when you're beginning. You need general anesthetic probably because at least in the UK, patients will only lie there quietly for about an hour and then things start to get uncomfortable. And you probably need CO2 insufflation. If you perforate, it's better. Patients are less uncomfortable afterwards. And of course, you need all those expensive knives. Although there's just a piece of wire and a plastic sheet, it probably costs, I don't know, 5 rubles to make. They're charging an extraordinary amount for it, for something very, very cheaply made. If you're on a budget, of course, you can use the tip of the snare and cut. They used to call that the flex knife. So my conclusion, ESD is, well, it's safer than TENS. It gives you a happier pathologist, have single fragments. They're less unhappy, should I say, less unhappy. And maybe it's better if the polyp is malignant. But of course there are consequences. It's much more expensive, much more resource intensive, it takes much more time, it's more dangerous for the patient, it requires lots of training, and of course all the other guys will have to stop doing it. You'd have to say, Mr. Gastroenterologist, Mr. Surgeon, step up, step away from the polyp, step away from the polyp, because only I can remove it, and this guy over here. It will upset a lot of people, I think. Thank you very much.
Все-таки удалось нам вписаться в регламент. Пожалуйста, 1-2 вопроса. Everything is clear. Thank you very much. Все понятно.
Are you doing ESD in Russia? Anyone doing ESD? Oh yes, yeah. It's like a train. It's coming. You can't stop it. It will just come. It's unstoppable. A bit like a poem.
Спасибо еще раз. Thank you.